Duchenne Muscular Dystrophy, or DMD, is a rare X-linked muscular disease that typically affects young boys, causing muscle weakness, muscle loss, loss of ambulation, and later cardiomyopathy. These factors lead these boys to suffer a significantly lower life expectancy. The physiological cause of the disease is loss of the membrane protein dystrophin at the sarcolemma of muscle fibers. Dystrophin is a fundamental protein that is part of the dystroglycan complex, which ultimately acts to stabilize the muscle cells and prevent damage to the tissues. Loss of dystrophin leads to loss of this stabilization, which is detrimental to muscle health and ultimately leads to muscle weakness. DMD can be diagnosed using a Western blot that tests for the dystrophin protein and using immunohistochemistry that examines the amount, or rather, the lack of dystrophin surrounding the muscle cells. As of today, there is no cure for DMD, but a number of treatments have emerged that show great promise in addressing the disease on a physiological level. This includes microdystrophin treatment, which restores a shorter but still functional dystrophin at the sarcolemma through the use of adeno-associated virus vectors, and eutrophin treatment, which utilizes eutrophin, a protein similar to dystrophin in function that is found at the neuromuscular junction, to act in place of dystrophin at the sarcolemma to aid in the stabilization of muscle cells. However, these treatments have yet to be used in clinical trials, meaning they cannot be used as today. Similarly, stem cells, while used in some clinical trials, have yet to show enough success to be used in DMD on a global scale. Consequently, today, DMD is primarily treated through the use of corticosteroids such as prednisone and deflazacort, which significantly prolong loss of ambulation in DMD boys and ultimately serve as a primary treatment option for these patients. Prednisone and deflazacort work by increasing muscle mass and strength through insulin-like growth factor stimulation, decreased cytokine production and lymphocyte reaction, enhanced myoblast proliferation, and synergistic molecules. By decreasing immune response in DMD patients, these drugs are able to limit the amount of inflammation and enhance muscle mass in these patients. However, there is widespread debate over the use of these steroids in DMD treatment due to a number of adverse side effects caused by these drugs. Some side effects caused by steroid use in DMD patients include stunted development, immune suppression, bone loss, and most notably, weight gain. The U.S. is currently experiencing an epidemic of child obesity, and the trend is continuing to worsen. Obesity is linked to a number of comorbidities such as diabetes, heart disease, hypertension, and liver disease, but rarely has the relationship between obesity and DMD been examined. The relationship between DMD and obesity is strange in particular because obesity in DMD patients does not result from the disease itself, but rather as a side effect of the steroid treatment. The physiology of how corticosteroids induce weight gain is rather complex and is evident in other pathologies in addition to DMD. Steroids such as prednisone mimic the role of cortisol in the body, and due to an increase in cortisol, these drugs ultimately induce effects common when cortisol levels are high. Well-respected pharmacist Austin Ulrich explains that high cortisol levels cause a bigger appetite, alter processing of sugar and fats in the bodies, and body fat buildup. And corticosteroids cause fluid buildup, which may also result in weight gain. Essentially, these drugs alter metabolic pathways, which leads to increased food consumption, fluid retention and edema, and fat storage. This presents a problem. DMD patients are unable to manage obesity in the same way as normal individuals would be able to through exercise. Physical activity, particularly eccentric exercises such as squats, are not recommended for treatment for DMD patients because they often induce irreversible muscle damage and worsen the phenotype of patients that perform them. A study examining the obesity in ambulatory versus non-ambulatory DMD patients found in the non-ambulatory group, exceeding the recommended caloric intake was correlated with higher BMI Z-scores, and BMI Z-scores were significantly higher in the group using corticosteroids. Corticosteroids prolong the loss of ambulation, but may contribute to obesity once patients inevitably lose the ability to walk. This, as well as a loss in physical activity, explains why obesity levels are higher in non-ambulatory DMD boys. These factors, in conjunction with a present as a dilemma of having to find alternate ways to manage weight in DMD patients. The obvious solution to this problem is implementing a strict diet in obese DMD boys. However, this may not be necessarily optional due to a multitude of factors. Firstly, Glucocorticoids induce an increased appetite in DMD patients, which means that limiting their food consumption, especially in children, would be difficult to accomplish. Secondly, food options may not be accessible to all DMD patients due to aspects such as socioeconomic class, food deserts, and lack of knowledge on where to find these alternative food sources. This isn't to say diet should not be targeted in overweight DMD patients, but rather that additional measures must be taken in order to ensure adequate weight management in these patients. As mentioned before, strenuous exercise is not an option for these patients and ultimately should be avoided. So the question remains, how can the effects of exercise be replicated in individuals who are unable to exercise? Firstly, the manner by which exercise causes weight loss should be examined. While exercising, stored sugars are converted into metabolic energy by way of biological processes such as oxidative phosphorylation and glycolysis. Weight loss itself ultimately occurs when calories, or rather energy in, is less than energy expended. Hence, one way to induce weight loss in these individuals is to increase metabolic activity in these patients. Several drugs purport weight loss effects, but oftentimes weight loss occurs as a side effect of the actual use of the drug. Topiramate is a drug that is used to prevent seizures and headaches by reducing bursts of electrical activity to the brain and restoring nerve activity. However, the drug has also been found to cause weight loss in patients that use it. In fact, in 2012, a topiramate oral capsule was approved to aid in weight loss in adults. However, even before then, the effects of the drug were long documented. In a study on the effects of topiramate in patients with diabetes, scientists found that after a year of treatment with the drug, patients saw decreases in both BMI and overall body weight. While there is no documentation on the effects of this drug in wheelchair patients, some promise exists in the possible use of topiramate in DMD patients. Other drugs have been approved by the FDA that purport weight loss effects, but there are some conflicting findings that make them not suitable for DMD patients. Semaglutide is another FDA-approved drug that is used to treat obesity, but it was specifically formulated for patients with diabetes. Semaglutide works by causing the body to produce more insulin when blood glucose is elevated. Diabetic patients often suffer from obesity due to high blood glucose being stored as fat. On the other hand, DMD patients suffer from obesity due to increased consumption of food as a side effect of the glucocorticoids used to treat their condition. If the overall cause of obesity is increased storage of sugar as glycogen and fats, then treatments targeting obesity should work to reduce this storing capacity. Increasing the amount of insulin secreted, while beneficial to obese diabetics, may further aggravate obesity in DMD patients. In fact, when approved in 2014, semaglutide was even stated by the FDA to be approved for chronic weight loss measurements in adults with obesity or overweight with at least one other weight-related condition, such as high blood pressure, type 2 diabetes, or high cholesterol. Therein lies the problem with most weight loss drugs. Not only are these drugs formulated for treating a number of other conditions linked to obesity, but they also work in conjunction with physical activity, which, as stated before, is not really optional for DMD boys. Hence, few pharmaceutical options exist for DMD patients to better control their weight. As of now, topiramate offers prospective treatment to better aid in the weight management of DMD patients, especially during their non-ambulatory stage. Nevertheless, clinical trials are necessary to test the effectiveness and safety of this drug in children, specifically DMD boys. The drug was originally formulated with the intent to reduce electrical activity in patients who suffer from seizures, but weight loss manifested as a side effect of the drug. This is due to loss of appetite that accompanied its use. If corticosteroids increase appetite in DMD patients, then a drug that leads to a loss of appetite should, in theory, restore the feedback mechanism involved in weight management. Still, going forward, the mechanism by which glucocorticoids increase appetite needs to be examined further. I imagine leptin levels are involved in some way, which means the drugs that increase leptin sensitivity may also help to manage obesity. Obesity cannot be ignored in DMD patients in favor of the large benefit offered by corticosteroid use. It is absolutely necessary to begin testing weight loss drugs in DMD patients so that they are both able to combat muscle weakness and degeneration caused by the disease and are able to avoid weight gain.